Oh, hi everybody.
Hello.
Hey,
Hello, good evening.
hey, I want to thank everybody for tuning in this evening. I am Andrea Clark Horton. I am the director of the Perinatal Mental Health Alliance for People of Color. And we are a program of Postpartum Support International. And this is our monthly conversation with some beautiful, it's Black History Month. I got on my African print.
Happy
See,
Black History
we got
Month.
African stuff on too. It's and so we're here because we want to talk with you about the village, right? And so there's this old African proverb that says it takes a village, usually to raise a child, but it takes a village also to support moms and families as you go through your perinatal journey. And so we want to talk with some specialists that are not psychotherapists. Well, I don't know, Dr. Taylor, you not no, okay. All right. We're gonna talk with some other members of your care team because we're going to talk about how perinatal mental health matters and how these other members of your care team can help you navigate, help navigate like what their role is and what they do. These are all wonderful alliance members, and Dr. Taylor, who's with us, is also one of our PSI board members. And so I'm going to start with her, and I'm going to have her introduce herself, and then we'll go to Elle and then Ariana. Okay, Dr.
Sounds
Taylor?
sounds good. Hi, everybody. I'm Dr. Nicole Taylor. I'm a reproductive or perinatal psychiatrist. I'm currently located in Jacksonville, Florida, where I work for the VA system. I also teach residents at the University of Florida. So I kind of wear a couple of different hats. I've been with PSI, Postpartum Support International, since 2012. I've been certified for the certification, the PMHC, since 2018, and I have been on the executive board. This is going into my third year now, and for the full board of directors, third year, first year on executive council. And I'm also the chair of membership for the national board and the chair of the professional outreach for the national board. And I am very excited to be here. So thank you.
We are so excited to have you. Thank you, Dr. Taylor. Miss L.
Yes, my name is Elle. I'm an occupational therapist, and I practice with mothers primarily or birthing bodies, primarily in the perinatal postpartum period. And getting into women's health was actually kind of birthed out of my own personal experience. So, first started out just really wanting to look at the psychosocial aspect and really looking at how engaging in preferred activities and occupations support our mental health. And then it kind of just went and expanded to training in lactation and breastfeeding. And now I am here in pelvic floor therapy, which is my passion and my love now. And so when we kind of think about this population and we kind of look at OT's role, we have a very distinct role that we can play in supporting the mother if we are to truly provide wraparound services, as I like to think about it, from hospital to home. I have been a member of PSI for about 2.5, 3 years, and a member of the Alliance for about a year and a half. So I am just excited for this opportunity to just share occupational therapy's role in supporting the mom and being that village and birthing bodies and humans, and not just those who have care with the baby, but for the extended family as well.
Absolutely. Thank you, Elle. All right, Miss Ariana.
Hi, everyone. I'm Ariana Stokes, and I'm a registered nurse. Mainly, labor and delivery has been the area that I focused on. And I've also ventured into nursing education at various levels, mainly with maternity, maternal child health, and leadership prep, and things like that. But I always tend to come back to labor and delivery. So if you've ever been in that setting, you've probably encountered a labor nurse or a postpartum nurse, depending on the environment. And I would say for me, although most of my experience has been in that acute setting, being involved with PSI has definitely opened my eyes to all of the things that come after. I'm recently becoming a mom myself. I have a 2 and 3 year old who literally came back to back, and recognizing that, the support that I wanted to lend towards friends and family members who were having children, growing their families, or, still in those early developmental stages, was more on the psycho-emotional side and wanting to better understand what that support looked like. Obviously, as a nurse, we're with you for a certain amount of time and then you're shipped off to a different floor and we really don't see or hear from you again. And so I think in being involved with PSI for the past year or so, and this year being, newly a part of the Florida Board of Directors as the community outreach liaison, I'm really excited just to get an idea, not only as to how we can better serve families, but also to understand, some of the different roles and, that maybe I haven't encountered in my own career that serve these families. So from the psychotherapist to occupational health and just really understanding what that village looks like.
Thank you, Ariana. Yeah, thanks for bringing that up because often I think that we take for granted that medical professionals all really kind of understand one another's roles and like who to call upon when your patient might be experiencing some things that are kind of out of your realm. Last month we had two of my former colleagues from the hospital who are hospital chaplains, and they came on and talked about faith. And chaplains very much consider themselves part of the medical team, and so I wonder if each of you, I think Elle gave a little bit, but Dr. Taylor, can you talk a little bit about what a psychiatrist does and like
Sure.
how is that different from psychotherapists and like in what situations you might be called upon to support moms experiencing perinatal mental health issues?
Sure, sure. That's actually a really good question. And I get asked that question all the time because a lot of people don't know the difference. So, a psychiatrist like myself is a medical doctor. So, I went through, college and medical school and residency and specialty training. And then my passion, of course, is women's mental health. So, I've done additional training in women's mental health, which led to the certification, etc. But really, the difference is that psychiatrists look at the situation more from a biological perspective. So not only are we looking at, how are you doing emotionally and psychologically, but we're also ruling out other common medical disorders and things that might happen during pregnancy. And we're also looking at the whole psychological and social environment. So an OBGYN might be focused on, blood pressure and blood sugars and, how big the baby is. Whereas a perinatal psychiatrist will look at all of that stuff, but also look at the psychological, emotional, and with health, general well-being of the mom. So a lot of what I get called in to do is what's considered the more complicated or serious kind of conditions, because medications are often involved, and that is where my specialty is. So when you asked me if I was a psychotherapist, I shook my head no, but that's with the caveat that I have also been trained in counseling and psychotherapy, and I do some supportive counseling, but my main wheelhouse, I guess you would say, is medications. So if a mom has depression or anxiety or other symptoms, bipolar disorder, any numerous number of mental health conditions in the past or during the pregnancy as new onset symptoms, then they often will call in a reproductive psychiatrist to assess the situation, make the correct diagnosis, and then determine if medication is needed, in addition to all of the other supports that we do through counseling and through support groups, etc. So they call in the MD when they're wondering if there might be either complicated medical conditions or there may be a need for medication to treat the emotional health of the mom at the
That's
time.
really, yeah, that's really helpful. I wonder if Ariana, can you talk a little bit about your role and like what you do and what how you might interact with other members of the medical team that's helping the mom?
Of course. So usually, the labor nurse is who you will encounter, probably the first person you encounter when you do come in to labor and delivery, whether it's to triage an issue at any point in your pregnancy, if you're having bleeding, cramping, any kind of concerns, or if you're actually in labor or feel that you're in labor, you come in and we're the ones to either triage you or take over your care, until baby's born. And we're with you all the way through the first 2 hours of what we call recovery. So the 2 hours following delivery. And so usually throughout that time, a lot of people I find that my role is more focused on the mom and, indirectly the baby. And obviously our only access and insight to the baby is through mom. We can't see or hear otherwise. And so a lot of that is, kind of looking at a lot of the biological things going on, but at the same time, recognizing what the emotional temperature of the room is and if someone needs to be pulled in as a consult to help address an issue. In my experience, those consults have mainly involved whether it's like a lactation specialist or social work, case manager, or maybe like a neonatal specialist or something of that nature, maternal fetal medicine specialist. So I'm really interested to hear when you're describing your role, Dr. Taylor. I'm like, who's calling you? Like, who? I've never, I've never been presented with that option to say, oh, maybe we should call the perinatal psychiatrist. Like, that sounds like a luxury almost, unless it's something not in that immediate setting. And most of my work does not involve a lot of long-term care unless the mother is there for maybe maybe she's there because her water ruptured at 32 weeks and or let's say like 28 weeks. We're trying to keep her to 32 or 34 weeks, so she might be there for like a month or so. But in general, if we do have a concern, whether it's respiratory therapy or something like that, we'll put in for a consult. We'll follow up and see if there's any next steps that we as the nursing team handle. And then typically a big part of nursing is doing what we call like a general assessment, where you're looking at the patient in general, head to toe. Are there any changes? Are they behaving differently? Are they looking differently than they were the last time? Who's in the room? Are they supportive? Are they causing more issues? How can I help manage that for them or communicate to this party on their behalf? And a lot of it is really advocacy. So I'm finding that there's a lot more consults that I guess could be called because we have our typical, standard few, but apparently there's a lot more that we have access to.
Yeah, I will say when I was a chaplain, the nurses and the nurses and the OBs were really a great source of like and the social work on that floor, but they were really a great source of referral for us, and we really worked well as a team, especially if the parents were in distress or things like that. So like I love nurses. My mom was a nurse for many years, and so not an L&D nurse, but she was a nurse for many years, and so I just have an immense respect for what you all do. And I'm wondering, Elle, like at what point are you called in as an OT? Like during um, before delivery, soon after delivery, or is your work like after mom is discharged, and where do you come into the picture?
So this is actually an emerging area of practice within our profession. And so just across the board, we are continuing to do advocacy work in terms of just getting those automatic referrals to occupational therapy while mom or the birthing individual is in the hospital. And the reason why is because we know that with pregnancy and also with delivery, we have those risk factors for comorbidities that can result in not only like pelvic floor dysfunction, but just loss of being able to do self-care task. And while we're known to be like the rehabilitation therapists and specialists for individuals who may have stroke or may have had hip surgery or knee surgery, we're not considered that same professional to care for the birthing body after they had the baby. But that is a procedure that also impacts the musculoskeletal system, the neuro system, that again impacts the person's ability to be able to do the things that they want to do, need to do, or is expected to do. And so we're advocating now for us to be considered a part of that care team because if we think about not only those who may have vaginal births, but think about cesarean births.
Baby, I was about to say that C-section.
That is being cut into, that is impacting the individual's ability to do lower body dressing, to be able to get on and off the toilet, in and out of the bed, in and out of their tub. And so as an occupational therapist or traditional rehab therapist, like we're already skilled and trained to address those deficits in occupational performance. And so even if I'm just addressing those daily activities, for practitioners who may not go into pelvic health, where we may have some pelvic floor dysfunction. So I'm able to add that additional skill set. So my goal is that the referrals happen while they're in the hospital, but also to follow the individual when they're home as well. So we can continue that care when they're in their home environment, because we can also adequately assess what are the barriers within their homes that we need to address,
Yes.
again, to make sure that they're able to do the things that they need to do to not only care for themselves, but also to care for their little one.
Yes, and I had a C-section. It was emergent C-section because my son was not coming out. I was 41 weeks and 5 days. He was not
Mhm.
coming out. And so I remember thinking like that wasn't my plan, but I'm glad my doctors pivoted. Like, and so I was thinking at the time, the place where I was living, there were so many stairs to get into my house. And then to get up to my bedroom and the second floor where the nursery was, there were so many stairs. You talking about hurt. I'm like, I wish they would have had somebody at the hospital that can show me, like, how am I supposed to walk up and I can't carry the baby up and down the stairs because so when I'm home and if I'm just by myself, it's me and him. So I wish I would have had an OT to like help me. I had that extra day in the hospital. I was like, no, y'all not sending me home with this baby. I had a C-section. I get one more day. I get one more day. Give me my day. Right.
And when we think about it, thinking of major surgeries, like C-section is one of the surgeries that the individual is expected to have done and to be up walking, peeing, and pooping within so many hours after it done. Any other type of abdominal surgery for any other reason, that is not the expectation. And so it's like, why are we putting that burden onto our birthing individuals? And why are we not referring them to the same service or level of care that we're referring our other patients who may be having some other type of abdominal surgery?
Or
That's
even
what I was wondering. Is there like a screening tool? Because I know when we do admissions, we ask questions like I know, well, depending on the records, some questions will include like, are there steps going into your home? How many steps? Like they're very specific. Do you have a bathtub or a shower?
Mhm.
And I know at discharge what the instructions look like, and a lot of them for many moms are probably very unrealistic. Like, don't lift anything heavier than the baby. What if you have a 4-year-old? What if So I'm wondering, when we input the answer to those questions, does it flag anything where it notifies like your team, or I guess what happens with that information?
Now, it really is, I would say, a hospital-based by hospital-based situation. There are some hospital systems where there is just that automatic referral to not only occupational therapy, but also physical therapy. And then there are just some hospital systems where we are still advocating to have those automatic referrals sent to the rehab team. Because again, it's not only about the rehabilitation, but we also want to address it from a health promotions. Because what if everything is fine, medically stable to go home. But then, as you mentioned, we get discharged home and we start having these challenges. Do these individuals have the information that they need in order to reach back out to their primary care providers to say, hey, I am having some challenges and difficulties performing these tasks. Can you refer me to occupational therapy? Can you refer me to physical therapy? So
right,
that is one of the reasons why we advocate adding rehab professionals as part of the postpartum care, just automatic referrals. And then we'll take it from there, whether we need to treat right there or whether we need to give anticipatory guidance. But at the end of the day, we just want to make sure that when they leave that hospital system, they have all the information that they need in order to continue with that care seeking behavior
mhm,
and not go home and feel like, oh, I just had a baby. So because this is common, we see things common, then it becomes normalized. And when it becomes normalized, we don't reach out and seek care. And that's just furthering kind of just sending us in a downward spiral as we're talking about like perinatal mental health.
right.
So
Dr. Taylor, did you want to jump in on this?
Yeah, so I think that y'all are bringing up a really good point. It really is. It's based on where you are, what system you're in, whether it be a hospital, whether it be an outpatient center, whether you be in a city versus a rural environment, because there really is a wide diversity of services that are not available in a lot of places. And if you don't know, you just don't know. And so I think Ariana brought up a really good point She said she didn't know that you could call the psychiatrist. Well, in a lot of places, you can't call the psychiatrist because there are not that many of us reproductive psychiatrists out there. And so one of PSI's missions, of course, is to train more providers, not just psychiatrists, but all providers. But, it's better if we get involved earlier rather than later. I do a lot of pre-pregnancy counseling for women who are trying to conceive, and they may have a history of some mental or emotional problems, or a family history of mental and emotional problems, and they want to be prepared. And it's always best to get the whole team involved earlier rather than later. So it is important that people know what resources are available in their area. And if they need help with that, then, that's one place where PSI can come into play to connect you to some of those resources and supports, because everybody doesn't have the luxury of having OT and psychiatry and all of these things. But it's good to know that those services are available out there to support you.
Right, which is part of the reason why I wanted to do this panel with people that you might not necessarily think of, right? And it's a shame, but we know what the numbers look like in terms of maternal morbidity and what happens to Black women in terms of postpartum complications, right? And having to really be advocates for ourselves. And so part of that is um, being informed about what actually, like, what is an occupational therapist? Like a psychiatrist, is a psychiatrist that deals with like moms and new moms or new birthing people. Like, what? I didn't even know that existed, right? Do you, to be able to at least ask the questions about, well, do we have one of those here, right? Um, Dr. Taylor and Ashley, who's watching us, says she wished she knew about some of these things, right? She wished she knew about some of these things before she had her baby. So, Dr. Taylor, I wanted to ask, because you talked a little bit earlier about being a prescriber and medications. And so we know that you work with, um, you're a perinatal or reproductive psychiatrist.
Psychiatrist, yes.
Right. So you work with this population all the time. And so you tending to mental health is primary to what your role is, right?
Exactly.
You talked about medications. So I know for a lot of folks, Black and Brown folks, that medications for mental illness are taboo, period. And so, um, how do you talk with patients about managing mental illnesses that might need medication, while they're pregnant or soon after postpartum? Like, how do you, I trust you. I trust that you know what you're doing. You went to school for a long time, right? You've been doing it for a minute now. But it's like, how do you foster that kind of understanding and that trust with folks?
Well, that's the most important thing that you can do, is to build that relationship and build that trust. You're right. Yes, there is definitely taboo and stigma around medication, but there's taboo and stigma around admitting that there's a problem. In our community, Black and Brown communities, we usually don't talk about these things. We need to, but we don't, because we don't want to be seen a certain way. We don't want our business out in the street. We don't want, people from other agencies getting involved. I mean, there's a whole lot of reasons.
Right.
There's historical trauma that has happened that makes us mistrustful of the healthcare system. Exactly. And so it is very, very common when I'm working with my moms and families. I don't just work with moms, I work with dads and partners and everybody. But when I'm working with the families, for there to be some caution, some concern about, is it safe to talk about what I'm really feeling? Is it safe to share my story? Is it safe to, put myself out there? And then when you put on the question of medications, people are like, oh my goodness, no, I don't want any medicines during pregnancy. What about my baby? I don't want to hurt my baby. But what I do, what our reproductive psychiatrists and perinatal psychiatrists and people who are informed in this area do is we do a lot of education. So we share information about the benefits and the risk of not only the medication, but the untreated illness. What a lot of people don't know is that depression and anxiety has effects on the baby. So it has changes that happen in your brain with the different hormones that can have long-term consequences that can make your delivery more difficult, that can make you have outcomes that you wouldn't want to see, like low birth weight, premature birth, increased risk of C-sections and forceps delivery. Things get go wrong because the mom is depressed and anxious and not receiving adequate treatment. But then you have to weigh those risks of the untreated illness with the risk of the medication. And there's no medicine that's 100% like safe. We can say there's, this is perfectly fine, you're not going to have any problem. But what we can do is look at the research, look at the information that we have, and say, okay, with all the babies that have been born exposed to this medicine, these are the things that we know could happen. This is the likelihood of that happening. This is serious, this is not serious, as far as side effects. And then we weigh those benefits and those risks against the risk of the illness in that mom's particular situation. Because it's a big difference if you have a mom who's never been depressed or anxious before and she's presenting with symptoms now versus someone who has a longer history or who may have a trauma history or have a lot of other things that are going on, medical, etc. So we sit down, we talk to them, we say, look, this is what I think is going on. I think you have depression, I think you have anxiety, I think you have bipolar, this is why I think you might have it. And then we talk about these are the options for treatment. We always discuss the medication options, the counseling options, the social support options. And we say, what's going to work best for you based on your history, based on your beliefs, based on your supports. Right. And we come up with an individualized plan. And this is a work in progress. I partner with my families and we discuss what's working, what's not working. And I follow them very closely from the beginning or before pregnancy throughout the whole pregnancy up until usually 2 years after they've had their child. Although I do have some moms I've had 5 or 6 babies with, so it's been like 12 years. but still, yeah, I follow them throughout the whole time so that we can partner and we can discuss what's going on. I answer questions. I provide online resources, sometimes written resources, books, whatever I need to give the most information and education to the families so that we can make the best decision for that particular family with that particular pregnancy, because each one of them is different.
I love that you said that. And I love this idea of partnership with the families. And so patients know that autonomy, like they have the ability to make, but you're saying you give them the information they need so that with their doctors, with their medical team, they can make the best decision for themselves. It's not cookie cutter.
Right.
It's not cookie cutter. I love that. But so we know kind of how Dr. Taylor fits into the picture with perinatal mental health. But Elle, like, how does perinatal mental health even figure into occupational therapy? Like,
yes. So as mentioned, OTs, our philosophy in terms of our profession, when we kind of look at health and wellness, again, is being able to engage in activities that you enjoy. And I think COVID kind of shed a light to kind of really help raise awareness when we talk about those habits and those routines and those performance patterns that we generally address in occupational therapy. And what we've just found through our own evidence-based research as a profession is that we're unable to do the things that we like to do, again, that we're expected to do. When our routines are disrupted, our habits are disrupted, that begins to impact our mental health, whether we have a history of mental unwellness or whether we don't. And I think, again, COVID kind of shed a lot of light on that for individuals who may not have had a history. And so that is what occupational therapists primarily assist individuals with being able to do, engage in their everyday life. Despite having an impairment, despite having an injury, the presence or the absence of a disease. But when working with this population, like I said, we get into pelvic health. And It is an advanced and specialized training beyond our 2.5 year, 3 year, depending on whether or not you go through the master's or the doctorate program. And so when we look at our pelvic health, we know that its primary role is looking at bowel, bladder, and sexual health functioning. And so,
Mhm.
again, being pregnant and that delivery process, it can impact our pelvic floor functioning. So that can lead to urinary or fecal incontinence. That can lead to vaginal dryness. That can lead to pain with penetration, sexual intercourse. And so, being a pelvic health occupational therapist, I'm able to address that. I'm able to hopefully be able to minimize the impact that pelvic health dysfunction has so that it does not, impact the individual's mental health. So, whether or not traditional OTs who's not specializing in pelvic health, that's sort of how we play a role in supporting perinatal mental health, looking at are you able to engage? If not, what's our barrier? What can we put in place? What piece of equipment? What modification or adaptation do we need to make into the environment in order for you to engage and participate? And then again, if it's a neuromuscular condition like the pelvic floor functioning, then we're able to kind of come in and bring in that specialized training as well. Because, especially when it comes to sexual and reproductive health, that is a huge part of our identity. And if we can't engage in that, again, we just think about all the psychosocial impact that that can have. So that's how pretty much our role.
I can imagine it's valuable to have, an occupational therapist that kind of is trained in this perinatal mental health, in this specialty, because you're able then as a member of the team that's caring for, this birthing person and their family, you can kind of like, I see this, like you can kind of spot some of the things that might slip by other members of the team that are not, trained in that way. Yeah.
Absolutely, because we just as general practitioners, we get to spend a lot of time with our clients. Most of our sessions are 45 minutes to an hour. Like you think about any other healthcare professional, they don't necessarily have that amount of time to spend with their patients. So there are things that comes up during our conversations that we're able to address, we're able to connect. And when you mention about that mistrust in the healthcare system, me being a
Yes.
person of color, I've been able to connect moms back into the system, including that behavioral health support. And as you mentioned, Dr. Taylor, that medication, it comes up, oh, I was recommended, some medication. And what do you think? And so I'm able, again, I have that time with them. I've been able to build that trust because we spent so much time. So I'm able to redirect them to a system that they were ready to walk away from and had, their walls up against. So that's been probably the most wonderful part of working with this population is to get them reconnecting and just reestablishing that trust with our healthcare
I,
system.
I love that. So Ariana, talk to us, because you said that you probably have the shorter term of like the relationships that folks on the panel have with these patients. Like you're there, you sit with them for through the delivery in a couple hours. And so like how does perinatal mental wellness like figure into your role?
Well, I think a lot of what comes into my role, a lot of people will say, oh, nurses are the hands and feet and the eyes and ears, of the doctor. So in the middle of the night, if something's going on with you and we have to call to wake that doctor or midwife up, we're the ones who are giving a full comprehensive report of what's going on so that they can decide from wherever they are what needs to be done intervention wise. And then outside of medical interventions, we have our own nursing diagnoses and nursing interventions that come into play that we're able to, own autonomously and decide, okay, what can I do so that it does not escalate to a situation where medical intervention is needed, especially if us being familiar with the providers and knowing what their typical plan of care might be. If a doctor is more likely to, rush into a C-section, decision, but we know the goals of the patient because we've talked with them, we've been in and out of their room, we've spent time getting to know their partner, whatever other support people they have there. And in doing that, we're also assessing like where is their mind at right now? What are their concerns? There have been some hospitals I've worked at where we'll have like a form, and the form is posted on the door that we go through with the patient, and it's describing, what is it that you are most fearful of right now? What are the things that make you feel most comfortable? How do you prefer, to be communicated with? And we kind of help guide them through what common answers may be. And in
Mhm.
that, it's allowing us to be able to see, okay, she's very apprehensive about things being taken out of her control, or she really prefers detailed communication. What medication is this? Let me know if you're going to check me. And, as the nurse, we're the ones doing the vaginal exams and all of that. So it's a very intimate relationship, even for that short amount of time.
Yeah.
Um, and also when handing off, we're handing off to other nurses at the end of a shift, or sometimes literally in the middle of pushing, we're the ones giving that full picture of what's going on and what's been taking place in the past 12 hours. Like, physiologically, here's what's happening. Mentally, here's what you need to know. These are the things that I've noticed kind of trigger her. This person, when they're here, we see the blood pressure go up. So it's best to encourage, just those little tips. And I think for me, my biggest role is creating a safe space. So, like when you, Dr. Taylor, mentioned, getting around that stigma and talking about the stigma. There's a lot of different stigmas that come up, even if it's not related to medications, but even say the epidural. I've had grandmothers pull me aside and say, who told my grandbaby about an epidural? Y'all done talked her into this? And I'm like, who told? Oh, we are all about informed consent. We give all the options. What is the concern? What do you think we're doing with that? Or what do you think the agenda is? And so recognizing these generational differences, cultural differences between the patient and their family members, between the families and the doctors, and being like a translator, a code switcher, an interpreter in the midst of all of that, I think it's really important. And I think that's why being part of this conversation is great, because hearing some of the different roles we have access to, I'm not usually in the postpartum section, but having been in that and recognizing just how quickly that rundown can go when it comes to discharge instructions. And in the meantime, they're trying to figure out what the baby's going home outfit is going to be, and do they have all their belongings. But to be able to say, hey, here's some things you might feel. Here's one thing that may differentiate it from another. Here's what you should do. Here's who you should call. And even now, although I'm not in the hospital setting right now because I'm with my little ones, but recognizing that in prepping my friends and family members for being in that environment, a lot of it, someone mentioned before, anticipatory guidance, like that's a huge part of it. So here's what you should expect. When you get there, they're going to say this, they're going to ask this. If you have this concern, keep repeating this. This is the key statement you should say. If you're getting discharged and you have questions, ask for this. And I notice a lot of times what's missing is the verbiage, knowing how to participate
Yes.
conversation. So being able to recognize, like you explained, Dr. Taylor, the difference between a psychiatrist, a psychotherapist, and, explaining the difference between an occupational therapist and a physical therapist, and recognizing when would you need to ask for that. Here's how you ask, who you ask, how you determine if you can pay for that, or where those services are found. What it will look like when they come to your home. Like, I like to know all of this so that I can make sure that I'm referring friends, family, and potential, patients to these sources, because in the hospital environment, those conversations aren't as long. And usually there's a lot going on to where the main issue is a safe and healthy delivery. And then there's that period after where not a lot is going to be remembered. So there's a lot of time for education in those weeks and months to follow, for sure.
Absolutely. We getting some love for the L&D nurses. Simone said that her L&D nurse was the hero of her first delivery, and we getting some love. Like, L&D nurses are it, honey. That you are it. So we are so appreciative of what you do. I think was it Dr. Taylor? One of you beautiful women brought up this idea of kind of the stigma and the things that we don't talk about in terms of being Black and Brown people, about our health, and especially true about our mental health. And I have found, when I was in the hospital setting, even though I was a chaplain, a lot of times my patients of color, they were going to tell me stuff that they would not tell the doctor, because the doctor was not a person of color. And so they would share things with me about how they were feeling, and so it kind of alleviated some of that, some of the, and I kind of sometimes had to act as a person who was the bridge for them to be able to trust the rest of the team, right? But I can't tell you how many times I walk into a room and then there's somebody would say to me, "I'm so glad to see you," like that, and do like that, right? So with that, is there anything unique? What are the unique considerations? What goes into your thinking when you're actually spending time in caring for and planning with patients of color around perinatal mental health, Dr. Taylor?
So first of all, like I said, I really work to build that trust and the rapport. So I just go forward at the beginning. What do you think I do? What do you want me to do? What are we trying to achieve here? Because I need to know where I'm starting from. So that's the beginning conversation.
Mm-hmm.
Because doctors tend to do doctor speak, which means I'm throwing out a whole bunch of big words that nobody can spell and nobody knows what they mean, and that is not helpful. So one of the things that I'm just very conscious of is that many people who have been involved with medical environments for whatever reason are already thinking, oh my goodness, this is not going to work. I don't know what they're talking about. Why am I here? And all that stuff. So I try to set clear expectations. I try to make sure that I'm talking in terms that make sense. And I say, if you don't know what I'm talking about, ask me. I'll say it another way. Use smoke signals, whatever I gotta do. We need to be on the same page to understand what's happening. But when I'm talking to my moms of color, particularly, I talk about the fact that I'm also a mother. I have a 18-year-old and a 13-year-old. That's a whole new situation, but but having teenagers, but being a mother of color, I know the pressures that are on us as mothers, as caregivers, not only for our children, for our partners, for our community, for our extended family members. We wear a lot of hats, and so most of the time, what I hear is, I don't have time to be sick. I don't have time to talk to you about how I'm feeling. I've got, 50 million things I need to be taken care of, and everybody is depending on me. So I have to keep it together. It's the strong woman syndrome, basically. And so that is something that is more prevalent in our community, I think, than in some other communities. Just that feeling the weight of the world, that you are responsible for everything and you can't break down.
Yes.
And so I talk about that. I talk about setting realistic expectations, that you only have so much time, you have so much energy, that you can't please everybody all the time, that you have to take care of yourself in order to be able to take care of everybody else. And I talk about how self-care is not selfish. So I spend a lot of time just dispelling the myths that we have to be super women, and helping people to understand that it's okay to ask for help, but more importantly, you have to be willing to accept the help.
That's right.
So that's probably the main sort of obstacle or barrier that I see. Now, obviously, depending on women's different situations, they may have experienced racism from their providers. Even providers that look like you sometimes have stereotypes that they, and experiences that can lead to, discriminatory behavior. And so I'll talk about that. What I try to do is create a safe space, just like you were saying, Ariana, create a safe space where people can come and be their authentic self, not be judged. And we work with where you are at that moment. Because I always tell people, you can only do the best you can with what you have at that moment. so that's really where I sort of start my foundation and move from there.
I love it. I used to tell my patients that were the helpers. They were the ones. I can't be sick. I can't be sad. I can't be none of these things. I help everybody else, and I help my daughter has got to go to school, and my cousin needs, and I'm just like, and you need help right now too, and it's okay. And so when somebody asks you for help, do you think of them as weak? Well, no, everybody needs help. That means you were everybody. You were everybody too. Like, so that means it doesn't make you weak to need help. It makes you a person. Right?
Exactly.
Any thoughts about, like, how do you support your patients of color? And are there other considerations, Elle, that go into, like, when you're working with patients of color or families of color?
Absolutely. Like Dr. Taylor said, I am all about bringing in my own personal experience.
Mm-hmm.
Because again, I think individuals look at us because we work in the healthcare system that perhaps we haven't had those same shared lived experiences. And so, if an individual is sharing their story with me, I am being vulnerable with them as well. And so
Mm-hmm.
that kind of helps kind of, again, establish that trust. But as Ariana said, having to address some of those generational differences. So, as I mentioned, being a pelvic health therapist, when we talk about urinary incontinence and we're talking about sexual health, that isn't something that was talked about within our communities. And you're going to be talking about that with a stranger, like you're having, again, pain with penetration, and that's impacting your relationship with we don't talk about that. And so, again, I create that safe space as well. And also create the safe space in bringing in their partner. So, like Dr. Taylor, when they mention, the sexual health and is impacting their relationship, I am referring them out to a behavioral health specialist who is trained to work with couples in their area while I'm doing the neuromuscular work with mom. But
Mm-hmm.
again, I think it's just being comfortable and being vulnerable myself with them and sharing my own story, and then just letting them know the services that I am either providing you or connecting you with are the services that I too had to take to support my own recovery and my own physical health and my own mental health and well-being as well. And again, just talking about having that village.
Yes,
You cannot do it all.
that's right.
And please don't put that expectation on yourself. And also helping them, I think, to change their language. Like a lot of my moms or birthing persons say, I feel like I'm asking my partner, can I go do something? And I was like, I get it, because again, the baby wants to be with us. So we're like, hey, can you watch the baby while I go take a shower? So just working with them on just their language and just say, hey, I'm going to take a shower, watch the
Mm-hmm.
baby for 25 minutes or so and go. So it again, it's a lot of just encouraging listening ears, providing that safe space. But most importantly, I found just being vulnerable with my own experience has been very valuable with shaping those relationships and just supporting my patients or my clients or individuals that I work with in mental health.
That's right. You're like normalizing, helping to
Yes.
normalize some of this. Like,
Yeah.
this is not unusual. Like, I
Yeah.
let me tell you, I know. Ariana, anything different for you? Are there different ways you work with your patients and families of color?
Well, I think for me, I have an opportunity to really kind of get a brief inside look as to the dynamics of either relationship or relationships within a family. We are pre-COVID, when you're allowing visitors in and you're able to see what does social support look like for this person. Like there's a lot of people in the room. How many of them are going to be there afterwards, especially if it's like a younger patient and there's a lot of friends there who are the godparents and they're all like early adults. And I'm like, okay, let me see what the support looks like. So for me, I like to linger, if the doctor leaves, I'll linger behind and I'll say, so what questions do you have? I try not to ask like the yes or no. Like, do you have any questions? Typically, it'll be no. So, what questions do you have? Tell me, what don't you understand about what's hanging up here, going in your IV, or what they just said?
Mhm.
Um, I'll linger if I feel like there might be a concern in the room, if I hear things getting a little heated, or I sense that maybe there are comments or jokes being made that might be making the patient uncomfortable. I kind of linger to see what some of the nonverbal communication is. And that way I can address whether it's dispelling myths, especially around breastfeeding. Like I've been in patients' rooms where, maybe they wanted to try breastfeeding. They didn't have a lot of examples of breastfeeding in their family, and all of their family is there. It's a very vulnerable time. Obviously, you're very exposed in labor and delivery. And there's comments in the room like, look at her nipples. And it's like, whoa, wait, like what's going on? I get maybe the nature of the relationship is like a roasting, but in this environment, there's a lot of fluctuating emotions and that might not be the place for it. So how to be a support and encourage in that space and to really make things that are, meant to be beautiful, have the opportunity to be that, and to really get a chance to understand what, like you mentioned, Dr. Taylor, what is your expectation? We in labor and delivery, we try not to say, oh, congratulations, you're ready to come have this baby. How are you feeling? How are you feeling about having this baby? Is this a wanted pregnancy? We don't know. Is there something going on where you're not happy about it, but you're going through with it and you're just hoping for the best? So I think lingering for me is the best thing, whether I'm just cleaning things up or I'm, just kind of listening in a little bit and saying, oh, actually, that's not true. I know you probably heard that, but really it's safe to do X, Y, Z. And if you need help, we can talk about it, and just being able to pop in on that. I think with my families of color, and ironically enough, in Florida and in California, most of my patients have been Latino, I would say. And I can remember probably their faces, the number of African American families that I've had. And it is always a special moment, when they see you and you make that connection. But I would say there, I feel like just kind of being able to put on, and not that we all speak the same code, so I'm not code switching to the same channel for everyone, but understanding like, let me relate to you so that you feel comfortable enough with me. I always give a code word, color or not, patients of color or not, so that if you say this word, I'll know to clear the room. If you need just time to think, if you need time without extra commentary, I'll say, just mention this word and I'll hear it and I'll give a reason for everyone to leave. And then you can just have a beat or you can talk to me or whatever. But I think with my patients who may have larger families or different dynamics, and I can relate to them or they think they can relate to me because we share that. I do try to be that, and I try to understand their motives and understanding, the information that they already have access to and how that's influencing their behavior or their decisions. Are they making decisions because they're informed or because they're scared or because they feel pressure? And I think being able to communicate that then to the medical team really helps to change how it may influence some of the care plans so that certain things aren't just, we're just going with the flow. Yeah, they said they were fine with it. Oh, well, just give me a second. Let me go talk to her real quick. Now I'll go back in there and say, girl, did you know? Did you want to know?
Correct.
And as a patient, I specifically chose a provider that I felt like I could have that kind of conversation with, that I know when I get to the hospital, I'm going to say, call Dr. So and so, tell him this, tell him I want this, I don't want this, and say, I know this is the rule, but ask him, and let him know I asked you to ask him, and that he's going to laugh and say, oh, that Ariana, okay. And I want to be that for someone else where they feel like I can talk to her comfortably and I don't have to figure out how to say it in a PC manner to get what it is that I need.
Yeah, I love it. Ariana, you like a little secret squirrel. You like a little private investigator in your private life or something. You back there just dusting and wiping off the windowsill, listening for all the tea. I love it. I love it. It just goes to show like how much each one of you just is so dedicated and passionate about what you do. And I really, really want to thank you all for coming on and sharing with me and being part of my village here with the Alliance. And so, for those of you that are watching and you want to know how to get into this village we call the Alliance, you can always visit us at postpartum.net. And when you go to join us, there is a drop down for the Alliance. And for those of you who are out there who feel like you're struggling and you don't quite feel like yourself, like you might need to talk to somebody, you might need support, please, 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 you are not alone. That in a few seconds, you're going to see the number for the maternal mental health hotline and PSI's helpline scroll. We have people standing by 24/7. If you're in crisis and you feel like you don't know if you are feeling like don't know if you want to be here anymore, please call the crisis number. And there will be somebody there to support you. Okay, so you are not alone. You are seen. You are heard. You're held by every one of these folks who are here. Even though we can't see you, we don't know you. Know that you're in our thoughts and in our hearts. And reach out. Reach out. We don't want you to feel like you have to walk through how you're feeling alone. Okay. All right. So to Dr. Nicole Taylor, to my occupational therapist guru Diva L, to Nurse Ariana, we want to thank you all. Thank you for such a rich and informative discussion. And we thank you all for watching, and we will be back at it next month with some new guests. Thank you all. Happy Black History Month.
Happy Black History Month.
Happy Black History
Happy
Month.
Black History Month.
Guys. I
Thank
enjoyed
you,
it.
everybody.
Thank you.